a
Yes.
speech. Yes.
Yes. Yes, we've changed it. So I contacted Guy this morning and it's been changed online. So her title, I presume her content is going to be the same. I think she just wanted a more generic title.
Yeah, okay. But I think I put it on our website.
Yes. Yes. Yeah. I think it's okay now.
Okay, thank you.
Can I just check in relation to the running order? Mark, do you give a general introduction and then I introduce the speakers?
Yes, that's right. Yes.
Okay.
I start. Farouk starts, and I start a second speaker, yes. and I give you the floor. Okay.
Okay. Yeah. Excellent. Thank you.
The virtual floor. This is what we do.
The virtual floor. Yeah.
Yeah, it's really a pleasure to be all together today. I just have a couple of minutes and give some information. This is only to open the session, and after that, I will let you completely the remote all this process. Yeah.
Okay. All right.
Is the presentation everything is okay with us? How we can make the everything is uploaded?
Yes. I think it's uploaded. I have the presentation of Mr. Vivo, Mr.
Goj.
Johan Goj.
Yeah.
It's just the presentation of
Dr.
Isabel de la Mata, and she hasn't sent it yet. The presentation, I think it will be okay.
Do you want the presentation? Because I was thinking on sharing myself as recommended, but as you want.
Up to you. Just manage it if there is any anything to fix, but it's okay. You can have the hand. You can keep it.
Okay. I will try to share myself if there is a problem.
No problem.
Can I just check? Johan's surname, is it Koch? Is that his surname?
My name is Koche. You pronounce it Koche, but it's difficult.
So how Koche?
Koche, yes.
Okay.
I will try to practice myself. I will try it first. The challenge will be this.
Yeah.
Sorry.
And I will see the questions come in on the chat. Is that correct?
Yes, I think that you can use the chat and everybody can use the chat window, and then just a kindly reminder that the session is live stream in YouTube now.
Okay. Okay, live stream.
And then, yes, it is live stream, and then you can have access to this live stream in our channel YouTube, or directly in the website of the Chaire Connected Innovation.fr.
Okay.
I think that Professor Yalawi had just he has an important call, and just a minute.
More important than us?
No, I think it is one of the organizer of the webinar. I think it is the right director of this is, I think.
No,
Okay. I think it's time to start. First of all, we're really happy to see you, all of you here today for this important moment. First, I would ask you to excuse my president, our president, Dr. Pierre Cor. He's not able to be with us today. Then, dear Philippe Bluat, Director of South Champagne Hospital, President of European Association of Hospitals Managers, my friend Marc Aster, General Secretary of European Association of Hospitals Managers, dear Chairperson, Miss Sharon Moreau, Director of Congenital Heart Disease Network, Health Management Institute of Ireland. We're delighted to have our three speakers from Belgium today. I think it will be in English, even there's both languages there. I will let maybe to be the good pronunciation to Sharon, but I will try to do it. Dr. Isabelle de la Matta, Principal Advisor on Health and Crisis Management of European Commission. Mr. Bertrand Bivort, French pronunciation, I'm sorry, I don't know why, but Manager at the Groupement des Hôpitaux Aigus ABSL, and Mr. Joan Kodge, CEO of DTU Architect. With my last update information, I want to share with you that we registered around nearly 100 persons registered for this session, which is really, really important. We are really happy about that. Many people from more than 11 countries, from Pakistan, Ireland, Vietnam, Lithuania, Luxembourg, India, France, Iceland, Germany, Belgium, Greece. Really, all the world is here to listen to the information and the topic that we share today. Thank you all for your participation. Today, the topic is effect of the pandemic on structure and process of health services. I will not say more. I will let you take the pleasure to listen to our speakers. This event is organized by South Champagne Hospital, European Association of Hospital Managers, Chaire Connected Innovation, and the University of Technology of Troyes. We are all happy that the webinar reached this third edition. The past two editions have gained a lot of attention. They were good ground for constructive debates and discussion around the world of healthcare, hot topics from the present to the future. The future is really important. There is many topics that we want to work on, and the target is very interesting. As Senior Vice President of Research of my university and Director of the Chaire Connected Innovation, I may have some few words about the Chaire Connected Innovation, which aims to tackle the challenge of Industry 4.0 with the world real data, big data, and different transition of society, technology, and the health. The main goal of our chair is to assemble and to gather intellectual experts and researchers to focus on energy to tackle the present-day hot issues of our society. And the healthcare and health is really important. To that end, the scope of this webinar is very important because the healthcare is considered as one of the pillars of our think tank among textile manufacturing, just to name a few of them. There are more number. Thank you to be here with us. I will let the virtual floor aside to Mark, and I hope you're really nice webinar.
Yes, thank you, Professor Yalaoui. Dear participants, I'm happy to welcome you in our third joint webinar organized by the European Association of Hospital Managers, EHM, together with the University, the Technology in Troyes, the UTT. Our previous webinars have already met with great interest. The topics were particularly interesting as we discussed medical data and quality and ethics in hospital and healthcare sector. Today, we will discuss the topic effects of the pandemic on structures and processes of the health services in hospitals, in homes for elderly people, healthcare networks, also mental health, as well as the activities of the European Union in the pandemics, the support instruments, the clearinghouse, and so on. We want to generate discussions and reflections based on experiences to stimulate improvements in hospital management. It's important for us to build the future on our experiences. The European Association of Hospital Managers wishes to increase its efforts to organize or participate in events that allow the players in the various fields and all interested parties to become actively involved in the current discussions. In addition to collaborating with national, European and World Hospital Association such as HOPE and the International Hospital Federation, the IHF, EHM is pleased to have established a partnership with the Université de Technologie in Troyes for the production of webinars on topics closely related to hospital activity. This partnership will not stop there. EHM is also actively involved in the organization of the Smart Healthcare International Conference in Troyes on 2nd and 3rd of December this year, organized on behalf of the South Champagne Hospital and the University of Technology of Troyes. You can find the announcement of all these events on our website, on the website of the EHM Association. The EHM Innovation Awards 2021 will be officially presented on this occasion, and I encourage all those interested in this challenge to consult the call for applications available on the EHM website. You should also know that EHM will soon announce a program for new joint webinars in 2022 with topics just as exciting as those of 2021. So this is an intense collaboration that I hope will continue for many years to come. Without further ado, I would like to hand over to Ms. Sharon Morrow, who will be moderating tonight's webinar. I hope you enjoy your evening with our speakers. Thank you.
Thank you, Mark, and thank you, Professor Nigan. Good afternoon and good evening, everyone, depending on your location. I'd like to welcome you to our webinar this evening. Just a little bit of housekeeping before we start. Each of the presenters will speak for approximately 15 minutes. If we have time at the end of each of the sessions, I will ask them any questions that you may have. If you have a question for one of our speakers, please put it into the chat box. If we don't have time to get through all of the questions, we will ask our speakers those questions after the webinar and make their responses available to each of you. Please note that we're also, this event is being recorded and we're also being live streamed, and you can access the live stream or the YouTube of the live stream after the webinar as well. So to our first speaker, that is Dr. Isabel De La Mata. Dr. De La Mata is a Principal Advisor for Health and Crisis Management in the European Commission. She is also the Director General for Health and Food Safety in the Ministry for Health in Spain, and I would like to welcome her to our webinar. Dr. De La Mata.
Thank you very much, and good afternoon to everybody. I'm going to try to share my screen, and I am going to speak about what the European Commission has been doing during the pandemic. Can you see the screen or not?
Yes.
Okay. Sorry, yes? I'm sharing the screen, yes?
Yes, we can see.
Okay. So the European Commission, since the beginning of the pandemic, has been supporting the member states. Sorry, there is a lot of noise. I don't know if are comments on my presentation, or it's just that someone has forgotten to switch off? Okay, so I was saying that we have been supporting the member states from the beginning of the pandemic. I know that there has been a lot of criticism to how the European Union has reacted to the pandemic, but I have also to say that they are not right. I mean, at the beginning of this pandemic in January and February 2020, everybody was a little bit disoriented, but immediately, I mean, already by end of February, and especially from the beginning of March 2020, we were completely on track and working all together, and with the support of the different European Union agencies like the European Center for Disease Prevention and Control, the European Medicines Agency, and also with the different services of the Commission and all the member states that were meeting almost every day, twice a week for sure, and the Health Security Committee also every 2 days, were trying to make a response. The EU response has been large, and not only on the pure health area. Of course, we have been supporting the research on vaccine, diagnostics and treatment, but we were also working on other issues, like at the beginning, the repatriation of EU citizens that were stranded in other countries, in third countries, or allowing the fiscal support to healthcare system, or issuing guidelines for different areas on testing, on spread of the viruses, or allowing the flow of goods and workers in the European Union. You remember when when even if we tried not to close the borders were closed, and there were what we call the green lines to allow all these goods that I mean, they were food, but they were also other very important supplies or medicines or other areas that were not to be stranded in one side of the border, and allowing also the health workers and other workers, essential workers, to travel over the border. That was especially important for countries like Luxembourg, as an important part of the working population is living in Belgium or France or Germany. We have been using different instruments that now I think that everybody has heard about the next generation, but the EU. But what we were using at the beginning were especially the rescue and the emergency support instrument. The rescue is the usual instrument that we are using during link to the civil protection response, and allowed that the stockpile of medical equipment that was stocked in some of the places that the European Union has in countries such like Romania, for example. We have one of the depots that could be deployed to other countries. But we were also using the emergency support instrument, that is something that was established in 2016 during the crisis of the migrants, and that they were revitalized in April 2020. And is based in one article of the treaty that allows the support among member states, and that is the instrument with which one we have been buying the vaccines, but not only that, the rapid antigen tests, the remdesivir, making training for health professionals, or mask at the beginning in May 2020. So we have dedicated 2.7 billion euros with this instrument that being for emergencies now is going to an end. I have mentioned before the guiding and support the member state, and those are some of the initial guidelines that we launched, like for example on the testing strategies, and I am talking about February, March, April 2020. So the really beginning, when nobody has a clear idea where we were, what was working, what was not working, and how we could solve the situation. Also guidance on the tracking apps for data protection, the advice on national vaccination strategy, also on vaccine strategy to develop quickly the different vaccines that we have now, and also working with the shortages not only of health workers but also of medical devices and other protection measures. The emergency support instrument was one of the instruments and was managed by the Commission, and I can say that we were paying for everything and giving the issues to the member states. But another instrument that we have been using is the joint procurement agreements. Joint procurement is something that is in our legislation in the decision on cross-border health threats, and that I mean, the member states are paying, but we are doing the procurement together. All the member states that are interested, plus the EA member state can work together and have, in this case, better prices, and also usually shorter delivery time. And we have been doing this joint procurement for several issues like gloves, coveralls, eye and respiratory protection, ventilator, laboratory equipment, medicines in intensive care units, or remdesivir, complementing the remdesivir that we were buying and delivering directly to the member state. So in one side, there was like a mutual collaboration in this joint procurement, at the same time that this was supplemented by the contribution of the European Union. We established another mechanism that was the clearinghouse. The clearinghouse was just that, like a repository where the ones that have something to offer, so the companies put there what they had to offer, and the ones that they were needing something, like the national authorities of the member state, but also individual healthcare facilities or regional authorities could consult. So we were doing here the intermediary with the offering and the demand, and facilitating the exchanges and the matching of supply and the demand. At the same time, we were having weekly meetings with the medical devices industry and the industry for protective equipment to know how the situation was going in general in the European Union and in the world, regarding the masks or regarding the gloves, or where we could be expecting that there will be a problem, or when we had the issue with the paracetamol, etc. So it was another instrument to join to the other one. From the beginning, it was clear that one of the issues that we were here together, and we can only live and win this situation if everybody is safe. So we can only be safe if everyone in Europe and in the world is safe and has access to the vaccine. And this is not only the EU and the neighborhood countries, but also other countries in the world. So this is why we spend so much time and money also, but effort on vaccines in general. And we designed the vaccine strategy and then the vaccination strategy, because it's not only necessary to have the vaccines, but how we are going to apply the vaccine. And this is why we are seeing, even if the vaccines have been provided to all the European Union member states, and also we are doing donations and contributions to the COVAX and individual third countries, but nevertheless there are huge differences in the vaccination rate, vaccination coverage that we are having in different member states. I'm going to explain something that we were quite proud, and that I think that could be of interest for you, that was also supported with the emergency support instrument, and was the training program for healthcare professionals on intensive care skills. This was developed with the collaboration of the European Society of Intensive Care Medicine, and the initial idea came when, from the very beginning, we didn't have enough health professionals. At the beginning, the professionals in the intensive care unit, they didn't know how to treat the patient, and they established, with the support of the platform that the European Union established for the rare diseases. So we had already a safe platform to exchange confidential data on patients that we were using to exchange among professionals new ways of treatment or ideas that they had or talking about individual patients. Then they came with the idea of a supplementary training to have more health professionals trained because there was not enough staff for intensive care units. And finally, we developed from August 2020 to May 2021 this project that has allowed us to train more than 17,000 health professionals, including medical doctors and nurses, and that has involved more than 3,000 trainers in around 700 hospitals in the European Union. So we conducted more than 1,000 hospitals, and we had responses from 700. It's not that the hospitals are not interested, it's that they were really very busy treating the patients, and not all of them had the possibility of participating in this training program. Almost all the countries in the European Union were, plus UK, because it was an emergency support instrument, so it's just restrained to the European Union. UK was at the time still benefiting for the program. Just 4 countries, 3 countries, sorry, did not participate. I'm sorry to say that Luxembourg was one of the countries that did not participate in this program. It was a pity. We tried everything, but it was not possible. So, but this is the distribution. I mean, of course, these are numbers, and numbers depend on the size of the country. So this huge number of trainers that participate belong to Spain. That is also a big country with a lot of population, but was not in relative terms, so in percentage, or taking into account the size of the population and the size of the healthcare population, was not the biggest one, the one with more participation. So, but you can see that a lot of people were participating. The program increased the knowledge of the trainees. This is what we had from the results of the test, because we had the test, we deliver certificates, and now the professionals that were trained, that was in a quite participative way, because at the beginning was, or the first part was e-learning, but then we developed on-site training, real, and when it was not possible was a virtual training with this 3D real virtual reality that was developed in the hospitals. This program already finished, but now we are negotiating its implementation in 3 countries that couldn't benefit before, and for that we are doing a negotiation with the European Society of Intensive Care Medicine and also the WHO. Another instrument that now we have, because it was approved in March 2021, is the EU for Health. The EU for Health is the health program that is dedicated to health in the European Union, and that has an envelope of 5.3 billion in current prices. It's from 2021 to 2027. And in order you to have an idea, the previous program, the 3rd health program, that was 2014-2020, was 460 million euros. So we have passed from 460 to 5.3 billion. So it's a huge increase, and we have put some minimum and some maximum. So in order to guarantee that we are not spending everything on administrative issues, there will be a maximum of 8% reserved to that, and a minimum of 20% on health promotion and disease prevention. But there will be an important part, and it's what I'm going to present you, that is for health system. This is just for the work program 2021. The work program 2021 is a small one, will be 360 million, but it's because we began late. The work program 2021 was approved only in June, so we have 6 months to spend everything. So next year, 2022, will be much more bigger. So for the health system, we have 68 million allocated for this year, and those are the priorities from improving access to healthcare to transfer of best practices and to EU health system resilience, with a series of actions, joint actions, grants or grants with international organizations. We are going to work with WHO, with OECD, with the European Observatory on Health System, and we will have also procurement. And one of the issues that will be quite important is the health workforce. The health workforce and the training of the health workforce this year and next year, 2022, will be one of the priorities. We need to do continual medical education to enhance the skills of the health professionals to adapt to the new technologies, but also to the different ways of working now, integrated healthcare, working in teams, and etc. And just to finalize some words about the European Health Emergency Preparedness and Response Authority, the Chaire, because has been a topic quite popular in the last week, because that was only approved last Thursday and was launched, is something that we wanted to create in some similarities to the BARDA in the United States, and that will have as a mission to address the serious cross-border health threats in a more dynamic way, and to avoid, to concentrate in the medical countermeasures, but also working jointly with the industry to reinforce the European Union industry, and to avoid that as we discovered at the beginning and in the middle of the pandemic, that 95% of the masks that are used in the world are not only made in China, but in Wuhan, so in the area that was more affected, so there were not masks for anybody, or that many of the precursors of the medicines are done in China and in India, and the borders were closed, and we had no precursors of medicine. And the opposite, that most of the vaccines in the world are done in the European Union, but there we had to export because we couldn't restrain the war of having the vaccines that were so necessary. So we need to work in collaboration with our countries and in a proactive way, and not only in the times of crisis, but in the times of peace, and begin to prepare for that. So we will have some tasks in the preparedness mode, and we will have like increasing the production capacities, prepare the procurement, the stockpiling, the distribution capacities, increasing the knowledge and the skills, but also in the crisis mode, how we are going to activate the mechanisms to monitoring, to procure, to purchase, to the different facilities and emergency research and innovation plan, and that we don't have to invent as happened this time. We hope that there will be no another pandemic, but this is quite improbable. There will be another pandemic. So we are now establishing the governance of this new authority with a coordination committee, Chaire board, with the advisory forum, with the collaboration of all the member states, but not only, because we also need the ones that have something to say, and the health professionals are key in this area. So this is why we will have observers, not only from the European Union institutional bodies, from the Parliament, from the Health Security Committee, where all the members of the European Union participate, but also from experts with a specific expertise on the theme that we will need in a given moment. And this is all. I try to be quick and as shorter as possible, but I think that I gave not much time for the question, even if I open to that. Thank you very much.
Thank you very much, Dr. De La Mata. I have two questions for you, if we can manage to squeeze them in. One is, what is the European Commission stance in relation to booster vaccines?
We don't have an approach. We are asking our agencies. We don't have an approach yet. I mean, we have been asking the ECDC and the EMA, The member states have taken different decisions, and of them are going to begin the booster, like for example Belgium for the immunosuppressed people. But what the ECDC has advised is that is soon to do that. That will be better to continue to increase the coverage of the vaccination. We passed the 70% of the adult population vaccinated in the European Union as such, but with huge differences among member states. There are some of them that are still on 20-something. There are others that are on 80 a lot. But of the adult population, and when we calculate the level of vaccination that we need, is done in the reproduction rate of the virus, how it's transmitted. And this calcul of 70% was done for the first variant, not for the Delta variant, the new variants. Now we have calculated, the ECDC has calculated, and other international institutes that are dealing with that we will need 90% of the population vaccinated, not of the adult population, but of the whole population. So as we are not going to vaccinate children, not yet, that will mean that we will need to vaccinate the whole adult population of the European Union. So it is better to concentrate on that begin to apply the third doses, in our view, but we rely on the ECDC, that is the scientific advice for us.
Okay, thank you. And one final question: will there be further funding from the EU for the management of long COVID?
Well, we don't found the treatment as such. We support the member states on building resilient health systems. What we will be funding is for the research on the long COVID. We are already, the HERA is going already to fund that. It's already decided and is already being prepared with the activities on the HERA incubator, that's for sure.
Okay, thank you. And thank you for your presentation. That was very informative, and it gives an appreciation just of the scale of everything that you had to manage across the European Commission. The numbers are starting. 17,000 healthcare professionals trained in intensive care is very impressive. So well done, and thank you for your presentation. I'm now going to hand you over to Bertrand or Bernard Bivor. Bernard is the manager at GHA and is responsible for looking after, through a group of acute hospitals, the recovery and management of the national stock of PPE and medical devices. Bernard has a fantastic CV, if I say so myself. He has been in his past times a commander in the army, a maths teacher. He has extensive experience in project management. He is currently studying for a doctorate in business administration and holds a master's in management and a master's in business engineering as well. So I'm very much looking forward to hearing from Bernard. Thank you.
So good evening, everybody. It's Bertrand, not Bernard. Huh?
Oh, sorry. Sorry, Bertrand.
I'm sorry, but my presentation is not perfect because I'm jumping in from somebody who is desisting. And so I will try to make my best to explain what Luxembourg did to manage protective equipment and medical devices in case of next pandemic. So I will try to share my screens. Sorry. Is it working?
Yes, it is. Yes, we can see it.
So I will try to speak shortly about Luxembourg's approach for a national reserve of personal protective equipment and medical devices to avoid the risk of shortage during health crises. So I will speak briefly about context, about the GHA, about ownership and management, and the operational frameworks, because there are two different frameworks. So a short explanation about Luxembourg healthcare with not specific, but it's typical Luxembourgish. So we have an universal coverage via compulsory health insurance and long-term care insurance. We have compulsory agreements for service providers with obligation to respect rates set by the National Health Fund, la Caisse Nationale de Santé. We have a preponderant liberal exercise of medicine, so our doctors are liberals. The patients have a free choice of provider and direct access to specialists. We have a centralized planning of the hospital and pharmaceutical sector, and we try to have a fair treatment of service providers. The finance of the health system is ensured by social contribution levied on salaries, contribution paid by employers, and contribution from the states. The governance of the health system is ensured by the Ministry of Health, by the Health Directorate and the National Health Fund. I jumped something. No. So during the first wave of the COVID-19 pandemic, Luxembourg, like other countries, faced a shortage of personal protective equipment, gloves, masks, clothing, glasses, etc., and certain essential medical devices. The crisis unit set up to manage the health crisis had urgently built up a national supply stock for this equipment and devices for the benefit of hospitals, the Confederation of Aid and Care Providers and National Protection Services. The experience acquired during the management of the health crisis has led the government to take into consideration the risk of a shortage of this equipment and devices during future pandemics by air transmission. Thus, the decision was made to create a national reserve based on the equipment and devices acquired during the health crisis. The management of the part dedicated to hospital and COPAs of this national reserve has been entrusted to the GHA. So, what does GHAs mean? Le Groupement des Hôpitaux Aigus. So, acute care hospitals are 4 in Luxembourg. So, the Centre Hospitalier du Nord, the Centre Hospitalier Émile Mayrisch, the Centre Hospitalier de Luxembourg, et Hôpitaux Robert Schumann. They built in 2020 a non-profit organization in the idea to take over this national pandemic reserve for the hospitals. And they create this non-profit organization, and they also take a member as the Aid and Care Association to provide them also in case of a new pandemic. So the role of this GHA is to take over the national stock of personal protective equipment and medical devices and is maintaining of the stock, because one of the problems is that when the stock is not maintained, it's depassed, everything is not usable afterwards. So a second objective is to develop a concept of reserve hospital infrastructure to coordinate cooperation with the University of Luxembourg and the cooperation within the framework of a military hospital with an idea to build in Luxembourg. So, but the main objective is to take over this national stock of personal protective equipment and medical devices. So, the process for this overtaking is, first of all, we make an agreement between the state and the GHA, who belongs to a transfer of ownership from this reserve from the state to the GHA. And now we are in the face of a public tender for subcontracting the storage, the maintenance, the replenishment, and the distribution, because we want that this reserve stay alive, so that it's, when possible, that the hospitals used equipments and medical devices. So the operational model, let's say in non-crisis period or in peacetime, it's that the Ministry of Health gives his orders to the Health Directorate, who has a general governance from the GHA. The GHA himself, he makes the tenders and the orders for the supply, from the maintenance for the new acquisitions, the refurnishing of the stock, of the reserve. And then we will have a service provider who effectively really does it. So he will stock in infrastructure, he will maintenance the stock, he will delivery, preparing and handling, etc., to the hospitals and to this confederation of aid and care. So globally, you see there are some information flows, there are some supply flows, and there are some distribution flows. So I think the explanation is relatively easy. So then we have a similar for a crisis. Then the overall governance is going up to the direction of of health, Directorate of Health, with a collaboration with the GHA, normally in a crisis team or crisis cell. The triggering of the crisis, so the possibility to use this reserve, it came from the Ministry of Health, who says, so from now on we use this reserve. The GHA has to do a follow-up about it. The service provider is then doing what he has to do, so preparatory handling. But in the tender, the possibility, also the quantity who will be delivered in a crisis is not included. So we should need some external transport society to deliver to the hospitals and to these different members of the Confederation of Aid and Cares. So it's globally the system. Thank you for your attention. If there are some questions, I'm open. Thank you very much.
Thank you, Bertrand, and thank you for your presentation. I have one question for you, if that's okay. In relation to the supply chain, did you have any obstacles, any problems getting your PPE through the various different steps in the process that you've outlined?
There are no major problems, but as usual, there are always problems somewhere. But so I stop sharing my screen. So, the major problem is that the view of the Ministry of Health and of the users, so the hospitals, are not necessarily the same in the way to delivery and the way to use the actual reserve. That's the main big problem. For the West, is only a public tender, European public tender, so it's not that complicated. But it's let's say a governance problem, between an understanding problem between the Ministry of Health and the different hospitals and different users.
Okay, all right. That happens in many places.
Yes, that's clear.
Could I also ask you, Dr. De La Mata spoke about a clearinghouse where they could check for quality. And I know in Ireland, obviously, we sent planes over to China to directly bring PPE back to the country. And there were issues with the quality of some of that PPE. How did you ensure that what you received was of good quality and distributed on?
So that we have now, we had no possibility to make quality checks. So we make quality check afterwards, and our experts has decided a lot of items we have in the stock in this reserve are not qualitative compatible with our needs. So that will be replaced, and then we will make a specific refurnishing tenders. And in these tenders, we will clearly define the quality, and we make quality proof, etc., before this refurnishing or replacement of the items will take place.
Okay, thank you very much, and thank you again. I know you were contacted at short notice to stand in, so thank you again for your presentation. I'm now going to go over to Johan Koh, I think is the correct pronunciation of his surname. Johan is an architect and CEO of D2 Architects, which I think stands for Design to Operate, if I'm right, architects in Belgium. This firm specializes in architecture for health, hospitals, elderly care, housing for the disabled, and education, as in schools. They're also active in public buildings with a higher social goal as well, which is nice to see. The firm have about 65 co-workers with various different types of skills and competencies: engineers, architects and interior architects, urban planners, landscape architects and furniture designers. And most of the projects are based in Belgium. Johan specializes in designing hospitals and the master planning of health sites. He was a leading architect of the iconic hospital Zeno. And I think that, is it Knock is a pronunciation for the city where that was? He can correct me on that. But I'm very much looking forward to hearing your presentation, Johan, and I will hand over to you now.
Thank you, Sharon. I tried to share my screen. Hope you see that.
Yes, we can.
Yeah. Very good. Thank you for the introduction. Just a little thing extra to say is that we were part of a task force for architects all over the world about COVID and pandemic. And that's a little bit our information that we can share now today. The problems that healthcare infrastructure faced during the COVID was for hospitals, the large number of patients in a short time, the presence or lack of qualified personnel and medical devices, the quality and efficiency of pandemic care, the possibility to allow ordinary care to continue in the hospital, and then the economic reality of hospitals that was not very okay during this period. For residential and care centers for elderly, it was also the number of sick residents in a short time that was a problem, the shortage of qualified personnel and medical devices, and then possibility for isolation and infected residents, cohorting of patients or residents, the quality and efficiency of the care, and also the problem of visitors and social contact between residents. And for residential houses for people with disabilities, the biggest problem was the visit of family and friends, and also the possibility of isolation of infected residents. So these were the largest problem. For this design and health task force, we had a few case studies all over the world. Present them for you. Our colleagues at Distravis from Australia were asked to were asked to analyze the existing Flinders hospital and to propose a solution to take care of COVID patients in the hospital without disturbing the rest. In the current situation, great interconnectedness was found between hot zones and cold zones, the hot zones COVID and cold non-COVID zones. It was also noted that circulations were not purely separated. The solution that was proposed was to isolate a separate part of the hospital from the rest, in which all the reception and treatment of COVID patients could take place. In the remaining parts of the hospital, normal care would continue. In South Korea, the government has imposed that a number of hospitals were reserved for the care of COVID patients. In the other hospitals, the normal treatment of patients could continue as usual. The Myeonggi Hospital is one of the designated hospitals. Here too, work is being done in phases, whereby a first part of the hospital is isolated and modularly enlarged. For an architectural competition we did for the hospital in Liège, the question was asked to propose a solution to deal with a pandemic. Our proposal was to be able to close a quarter of the hospital from the rest, where almost all reception, research, and treatment of COVID patients can take place. Initially, the lower part was isolated. As the pandemic grows, other parts of the hospital are being included in the pandemic part through a separate vertical circulation. For example, modular nurses, nursing departments, intensive care units, treatment rooms can be added over different levels of the hospital. The rest of the hospital can work normally. In smaller hospitals, it's not always possible to isolate entire parts from the rest. Therefore, the departments in the hospital should be able to be split up if necessary. In the proposal for the Hospital of Lier, a normal ward of 12 intensive care units is combined with a stroke unit of 4 beds. With few COVID patients on intensive care, the isolation boxes are used, also in the top. And by extension, the department will be split up, and part 2 will be a full COVID intensive ward with under pressure ventilation. The part 1 of the intensive care unit can accommodate the normal patients. From these cases, we had some general lessons and impact on the future design of hospitals. We noticed that the COVID pandemic has magnified existing problems in many healthcare facilities that were already there before the pandemic. We need to make a clear distinction and solve these problems first. Will there be another similar pandemic or another big problem? What will be the infection degree, the dispersal forms? We don't know what's coming our way, so we should try to do infrastructural interventions that also have a positive impact outside of the pandemic. The flexibility is the key word in that case. If possible, agreements must be made within a region or care network which hospital accepts COVID patients and which do not. The financial expenses and revenues must therefore be compensated between hospitals. The provision of reserved quotas for beds or intensive beds for each hospital means that no hospital can function economically and is disturbed in its daily operation. That was the case in Belgian hospitals. It's better clear distinction between not COVID hospitals, partial and full COVID hospitals. The division is, of course, flexible over time. For a non-COVID hospital, it's necessary, or not a complete COVID hospital, it's necessary to use other accesses for COVID and non-COVID. Certainly for patients, but if possible, also for personnel and logistics. These separated, isolated entrances must also remain completely separate from the rest of the hospital inside. Contrary to the idea that the hospital must have only one entrance for control and overview, various services of the hospital could be accessible separately, outside streets and squares, and separated from doors. Test centers must be organized outside the hospital so that no unnecessary and infected persons enter the hospital. The emergency department is an important gateway to the hospital. Due to the severity and acute nature of the patient's problem, every patient is potentially infected person. Until there is a negative test, all patients must remain potential positive. The patient therefore prefers to stay at the emergency department itself for further examinations. In principle, COVID patients go to the separate COVID section of the hospital via a secured route, outside or inside. The complete separation of the COVID section from the rest of the hospital is the only guarantee of a lasting smooth functioning of the hospital. This section should be used in non-pandemic times for less essential parts of the hospital, such as a convention center. This implies that various departments must be accommodated in the COVID section and that the necessary examinations can be done in this section. On this part of the hospital, there must be the possibility to provide a temporary modular extension to provide an additional capacity specified to the needs of the moment. This implicates sufficient free outdoor space to be able to set up temporary constructions. Because we never initially know how big the problem will be, we must have the opportunity to grow the measures and the reserved infrastructure in a modular way, according to the needs. This infrastructure must therefore be super flexible to cope with the changing circumstances. The hospital infection and control prevention team is going to become a louder voice in many design meetings going forward. There will be increased pressure to make design features more easily cleaned and use finishes that withstand harsher chemicals. More health systems will use UV lights or sterilizing mists in high and medium risk areas. Low risk areas, like exam rooms, will need more thorough cleaning protocols and room turnover processes. The biggest conversion most facilities have undertaken during the pandemic is increasing the number of isolation rooms. Going forward, hospitals will need groups of rooms, and entire units and wings can be negatively pressured and cut off from the rest of the hospital in a pandemic. These units will need easy ways to get patients from the emergency department as well as trash out without going through the entire hospital. In order to keep all traffic within the hospital well under control and to avoid cross-infection as much as possible, all flows in the hospital must be clearly separated. Visitors, ordinary patients, infected patients, staff, personnel in contact with contamination, clothing, goods, waste, all streams must have a clear circuit with separate entrances, corridors, and elevators. Separation is mainly physical, but can also happen over time. Ventilation, we should have better ventilation in all parts of the hospital. We should have better separation of air management between departments, services, and rooms. And ordinary rooms should possibly be in negative pressure or overpressure. Nobody liked the waiting room previously, but now it seems inconceivable that people will be willing to sit next to possible infectious strangers while they wait for an appointment. Trends like self-checking in and self-rooming will accelerate to minimize interactions with other people. All public spaces, including lobbies and dining facilities, will have to be carefully planned and designed to create a greater physical separation between people. We should use more the outdoor spaces. Patients and families will be encouraged to wait or walk outside. More examinations should take place outside the hospital. Telemedicine has boomed throughout the crisis, allowing clinicians to perform routine checkups and triage with patients without putting either doctor or patient at risk. While the future reimbursements for telemedicine is unclear, the impact on our designs will be tremendous. The technology is relatively cheap. Physicians can see more patients in the same amount of time, and there are low space requirements. More of the activities should be digitalized, so conversations and consultations can perhaps be done over video. And at last, we have to create more touch-free, so touch-free control for lighting, temperature, doors, and sinks. So here we have a list of special things that we should take in mind when we do new infrastructure for healthcare or changing existing healthcare facilities. This was, in a nutshell, the architect's view on future healthcare facilities. So, thank you for your attention.
Thank you very much, Johan, for that very interesting presentation that raises, I suppose, anyone who's involved in particularly hospital management and hospital design, a lot of questions around what our current buildings are like and how fit for purpose they currently are and will be into the future. Particularly, I'm sure you're no different in Belgium in that you have some older buildings there too, the same as we do in Ireland. I'm particularly interested in relation to outpatients. How do you think we could plan for that in existing buildings going forward? And I agree that the days of having waiting rooms full of patients are probably behind us.
Yeah, that's. I'm an architect. I'm not a doctor or a manager of the hospital, so that's not directly my. But perhaps we should separate those from the normal hospitals. So perhaps we should have more accommodation, more little accommodation, and not the big hospitals. But that's only my point of view. I don't know how it is for a manager to see that. So.
Very good, very good. And I think you're right. It's probably looking at alternative sites for outpatients, and again, like yourself, the use of telemedicine to support that where we can as well. Thank you. That was a very, very interesting presentation, and certainly for me raised a lot of things that I hadn't necessarily considered, particularly I suppose around COVID hospitals, non-COVID hospitals, and partial COVID hospitals. Did you have, I suppose within, I'm not sure if the hospital structure in Belgium is the same as it is in other countries, but if you had a city with a number of hospitals, how was the decision made, particularly for hospitals that would have certain specialties? How was the decision made? What hospitals became COVID hospitals and which ones didn't?
No, in Belgium, that was not the case. It was just a suggestion because that was the case in South Korea. There they took it. So the problem in Belgium was that the hospitals cannot work completely free. They have to reserve some beds and intensive care units for in case that patients come in. So they have to it's a mix. I think all the hospitals have had to keep beds free. There were no COVID and non-COVID hospitals, but I think, and that's a suggestion, that it would be better to designate some hospitals to take all the patients and let the other hospitals perhaps work normal. But we are not good organized, not yet, to do that.
So hopefully lessons learned from this pandemic and preparations in place should we ever experience again. I'd like to thank our three speakers and thank you for those who submitted.
I have just a little question for Mr. Johan.
Oh, please. Yes, go ahead.
Yes, sir. Thank you for your presentation. I am Quy Nguyen. I am researcher from the Chaire Creative Innovation. And it's really interesting, your presentation, especially the idea about the pandemic section and the idea about the flexibility and the modularity of the hospital. So I just have one quick question: that do you have the indicators of the flexibility? So how can you measure the flexibility of the design of a hospital?
Flexibility is a simple word, but it means a lot. It means that in principle, you can do everything for hospital activities in one place. So flexibility means that you have free space, that you have high spaces, that you can easily change the walls, and so that you can easily change things in a construction. That's easy to explain, but that's not so easy to do. But you can be modular in your layout, so it can be used for multiple functions. So
you just have a metric, a precise metric in the flexibility, for example, for the material of the use of material, of the use of spaces, of operations. Yes. Yeah. Just do you have some indicators, some measurement for this flexibility?
That depends. But we use a matrix of as large as possible. But it's a combination of what's economically possible and what's usable. So now we use let's say 8.5 meters to 8.5 meters, but we prefer to have 10 to 10 meters for the construction, for the columns to be in a matrix. But the larger it is, the more flexibility you obtain. But let's say that 8.5 meters is an economic way of building.
Yes, thank you very much. Thank you very much. I think that there's another question from Mr. Paul Pomke, I think.
Hello, yeah. Can I?
Yeah.
Okay. So 2 comments. First comment is that we have to aware that what we call in my country, in Germany, the Bologna Effect. When you bring all COVID patients to one place, then you will infect the whole community. So we decided that it's better to have little places in different regions where you can treat and where you can care for the COVID patients. This is one, so we call it the Bologna Effect, because we realized that it's not good to bring all the COVID patients to one place. Because you spread the disease around the region or the country. Second comment, hospital is not hospital. So I'm a CEO of a psychosocial hospital provider. So we have psych hospitals, and you cannot put patients with mental health problems into a normal COVID hospital. If you do this, then you will spread the whole COVID situation all over the hospital. So when we think about a good organization or a good structure for COVID or for pandemic reasons and mental health, we have to open up our minds and think a little bit totally different. So My suggestion is that in this place, we have to think more about improving assertive community treatment to keep the COVID situation in the communities where it was detected. Thank you.
I agree that it should not be all concentrated in one hospital, but the example of in South Korea was that they designated 30 hospitals all over the country for the treatment of patients, and it's perhaps not good to transport patients, but it's the problem of all the hospitals was that they couldn't work normally. So they had big losses financially, and they couldn't work. And some of the other patients could not be treated because of the COVID. So that's a thing that we should take care of, that we also can treat other people. And we not only have to concentrate on the COVID. So, but I'm not a manager, so I think you're better aware than I how it should be arranged, but that's how it was in South Korea.
I think that's Mr. Pomke has another.
Yes. Sorry for another comment. I think it depends on the culture you live in. You just said a dirty hospital. Just think about the staff. Nobody wants to work in a dirty hospital. And no community, no mayor would like to have a dirty hospital in his region or in her region. So you can do this. It's one option, but I think we have to have in mind that there are different cultures in coping with hospitals and disease management and so on. So my personal experience in the last 2 years was that it was good to have specialized hospitals where you can treat COVID patients and you can treat other patients, and you have hospitals where there's a normal treatment. And when you have a COVID patient, then you decide with the more specialized hospital if you transfer it to the next level, for example. So, but this is not the solution. It's one solution. It depends on which culture and in which structure you live in. So I think in my region, there won't be a big discussion about dirty hospitals, and nobody would want to go to these hospitals anymore.
Yeah, I can imagine that. Yes, it's probably one problem that we have to face if we do.
Mrs. Morrow, maybe for.
Yes, I'm sorry, I can't actually see the questions coming in. But if there are no further questions, I'm happy to wrap things up. I can let people know that the live stream can be accessed on the Chaire Connected Innovation.fr channel or on that website if people would like to or have missed any of the speakers and would like to look at it later on. And I would like to take the opportunity to thank you all for joining us this evening, and also again to thank our three speakers for a very insightful and informative perspective on their experience of working in the pandemic. Thank you.
Thank you.
Thank you, Sharon.
Thank you very much.
Good evening.
Good evening.
Before closing our webinar, I would like to thank all the people who made this webinar tonight possible. First of all, thanks to the speakers for the high level of their presentations. Sharon Morrow for the excellent moderation. The team of the University of Technology in Troyes also for the technical aspects. And of course, all the people who joined us tonight to participate and to listen to the speakers. I would also like to invite you to the next webinar, the fourth webinar, joint webinar on the theme will be corporate social responsibility, social networks, and social impact of the COVID-19 pandemic on the different health systems in Europe, which will take place on Wednesday, the 24th of November, also from 6 to 7:30 p.m. And for those who wish to listen to tonight's interventions again, as Sharon said, I remind you that the webinars co-organized by EHM and UTT can also be followed in streaming mode. Thank you all for the interest in our events, and see you soon, I hope. Thank you.
Thank you, Mark. Thank you.
Thank you very much. Just to say one word, Professor Yalawi had to leave us, and just on his name, I would like to thank all the participants for attending this webinar, and we hope to see you for the next edition. Thank you very much.
Thank you.
From the University of Technology of France.
Thank you. Bye-bye.
Thank you, Mark.
Thank you.
Thank you.
Thank you.